During the session, it's important that you know that you are able to ask questions. Just post them, we will collect them for you, and we will make sure that the questions are addressed properly. For every session, we have a quiz question. Please join the quiz. You can earn GIEQs points by giving the correct answer to the quiz questions. And maybe we can display the first question for this session. I personally don't see the question appearing. Yes, so which of the following is true? A brushing of a distal bile duct stricture can usually rule out malignancy with a high certainty. There is no risk of cholecystitis when a covered self-expandable metal stent bridges the cystic duct. For distant malignant bile duct strictures, a covered SEMS performs better than a plastic stent. And last, the usual length of the common bile duct from the ampular orifice to the liver hilum is around 6 centimeters. So please answer this question. I leave now to the endoscopy room myself, and I give the word to Professor Harald Peters, who will give the first talk of this session entitled The Differential Diagnosis and Diagnostic Workout of Distal Bile Duct Strictures. Thank you.
Thank you, Peter. Good morning, everybody. Thank you for this kind introduction. I'm just waiting for my slides here. Okay, good. I have no financial disclosures. Okay, so it's important to know that the majority of distal biliary strictures are actually malignant, about 70%, and most of these cancers have a poor prognosis, so early diagnosis is absolutely very important. And these are the most important cancers we have to think about, and we will mainly focus upon the first 3 ones, and then, so of course, we think of pancreatic cancer, distal cholangiocarcinoma, and we will also touch upon ampullary carcinomas. Nevertheless, about 30% of strictures in the distal bile duct can be benign, and of course we absolutely want to avoid unnecessary surgery in these patients. So these are the most common benign causes of distal strictures, and of course we think of chronic pancreatitis, but also autoimmune pancreatitis, benign ampullary lesions like ampullomas, IgG4 related cholangiopathies, but also but more rarely primary sclerosing cholangitis of distal bile duct, post-surgical strictures, and then these other 2 chronic inflammatory disorders of the bile ducts. This is the most typical clinical presentation of a distal biliary obstruction, and in case that jaundice is painless or silent, then we really have to think of underlying malignancy. Of course, we will look for other signs and symptoms that might direct us to the underlying cause of the problem, and here we for instance, we think of new-onset diabetes in patients with pancreatic cancer. Relapsing cholangitis can be a sign of an ampullary problem. Alcohol can cause chronic pancreatitis. IBD and PSC are related, and so on. Lab testing will rarely help us in diagnosis, although it must be said that bilirubin seems to be a very strong predictor of malignant disease. So the higher the bilirubin level in the blood is, the higher the likelihood of an underlying malignancy. And on the other hand, in case of normal liver tests, underlying malignancy is quite unlikely. IgG4 can help us in diagnosing autoimmune pancreatitis or IgG4-related cholangiopathy, but it can also be elevated in PSC and cholangiocarcinomas. And concerning tumor markers, they are actually of little value in diagnosing or staging of these distant malignancies. So this means that we need other diagnostic tools to have our diagnosis. And most of the times, of course, abdominal ultrasound is the first imaging technique that will be used because it's readily available, it's cheap, it's quick, and it gives us with a high sensitivity an idea upon bile duct dilatation and even upon the level of obstruction. But nevertheless, cross-sectional imaging is mandatory and is the essential next step. And then, of course, we think of CT scan, multiphasic CT scan, and MRI scan. And these 2 techniques then will direct us towards the possible need for other techniques like EUS or ERCP with or without tissue sampling. I will also touch briefly upon these newer techniques which can be used in indeterminate strictures. Let's have a look at pancreatic cancer first. So although abdominal ultrasound can detect pancreatic cancers in the head of the pancreas with a quite good accuracy, we still need cross-sectional imaging for a good diagnosis and staging. And despite the fact that CT and MRI are quite similar in results concerning sensitivity, specificity, and accuracy, CT scan is still nowadays the preferred modality for pre-op staging and resectability evaluation, probably because of the good availability of this technique and the relative low cost. PET-CT is much less important in diagnosis, is mostly used for follow-up after surgery or radiochemotherapy. But another very important cornerstone of diagnosis and staging is endoscopic ultrasound. And as Olivier de Witt showed in a very nice review in 11 studies, EUS seems actually superior to CT scan concerning T-staging. So it means that EUS will have less overstaging. For end-staging, results are similar. And EUS seems specifically very interesting in smaller tumors, and of course it has the advantage of getting tissue sampling via fine needle aspiration or biopsy. ERCP has lost its importance in the diagnosis of pancreatic cancers. It's mostly used for palliation or decompression, although you can have some typical signs of malignancy on ERCP. But in some cases, it can be useful because of the tissue sampling that can be done by brush cytology and or forceps biopsy. With regard to tissue sampling, it's important to say that in case of a resectable pancreatic cancer, that tissue sampling is actually not necessary. It is also mentioned in the guidelines of the European Society of Medical Oncology. So actually, tissue sampling is only needed when there is doubt or when in cases of metastatic disease or need for neoadjuvant treatment. And then for pancreatic cancer, it's quite clear that the results of an EUS with FNA is clearly superior to cytology brush and forceps biopsy via ERCP. ERCP with brush has a quite low negative predictive value and low sensitivity. Let's have a look upon distal cholangiocarcinomas. Here, MRI is really the preferred option, and on the right side you have a nice image of a distal cholangiocarcinoma with the specific malignant features that you can have on these T2 weighted images. MRI gives us a nice idea on the location and the extent of the tumor, but also on the anatomy of the biliary tree, which can help us, of course, when we perform ERCPs. It has a quite good sensitivity and specificities, although, of course, histological confirmation needs to be done. And again, here, this can be done by ERCP with brush and or biopsies or EUS with FNA. ERCP has, of course, the advantage that a decompressive stent can be put in place. With regard to the tissue sampling, you see here that sensitivity of brush and biopsy is quite low, but if we combine both techniques, results are quite better. On the other hand, EUS has the advantages of a good T staging, so tumor detection, extent of the tumor, and also an evaluation of regional lymph nodes. And FNA is mainly useful in distal biostructures, which is logical. And as opposed to pancreatic cancer, where FNA is clearly superior for tissue sampling, here the combination of a brush and biopsy via ERCP has quite similar results as compared to EUS with FNA in biliary strictures or indeterminate strictures. A small word on ampullary carcinomas. Here on the right side you see a typical image with a double duct sign up to the papilla, which you see here nice on these T2 weighted images. Relapsing cholangitis is a quite typical feature here, and MRI has actually a relative good accuracy. Nevertheless, ERCP and EUS are the preferred imaging techniques, and often they both are combined. They give direct visualization of the ampulla. Direct biopsies can be taken. via ERCP, a decompressive stent can be put in place, and EUS gives us a nice idea on the resectability of the lesion, and with a good accuracy for diagnosing malignancy with FNA. Nevertheless, there are some cases in which diagnosis remains indeterminate, and we will have inconclusive histopathology, and in these patients, these newer diagnostic techniques can come into play. Cholangioscopy is the first technique I want to discuss here, and now with the spyglass we have the single operator cholangioscope, which is easy to use. The cholangioscope is introduced through the working channel of the duodenoscope. It gives a nice direct visualization of the bile ducts, as you see on the right side here, but also on the stricture, and you can have some directed biopsies of the lesion, which gives you a very good specificity and sensitivity. And there are some drawbacks here, of course, with this technique, and this is mainly due to the low availability of this technique and the cost price. Second interesting and promising technique is intraductal ultrasound, where a radial ultrasound probe is introduced via the ERCP scope over a guide wire. It has quite good accuracy for malignancies, and it gives an idea on the tumor, the extent of the tumor, but also on periductal invasion and the presence of lymph nodes. But again here, training and availability and cost are the main issues for this technique. And then the last one here is confocal laser endomicroscopy, or PCLE. This gives us the possibility of a kind of virtual biopsy. So we have in vivo histology of the epithelium of the bile duct. It is performed during ERCP and can be combined with cholangioscopy. Quite good sensitivities and accuracies, but here again availability and cost are main issues, as well as a important learning curve. I would like to use this flow diagram as a summary of my talk, and it was a diagnostic approach which was proposed by the group of Mariana Arvanitakis from Erasmus in Brussels in her very nice review, which I urge you to read on this matter actually. So in case of a suspicion of a distal obstruction, cross-sectional imaging is mandatory, and this will then direct us further on. If we detect a mass and the mass is resectable, then EUS will be performed for further staging, and patients will be sent directly towards the surgeon for an operation. FNA is only needed if neoadjuvant treatment would be necessary. In case the mass doesn't seem to be resectable, then it depends upon the location. If the location is the ampulla, then duodenoscopy with biopsies, and EUS is then the next step, and FNA only if necessary. For the pancreatic mass or distal cholangiocarcinoma, here EUS and FNA will be the first technique used. In case there's no mass visible on cross-sectional imaging, then EUS and FNA will be performed. If no diagnosis could be made, ERCP and brush with biopsies can be done, and this can be repeated if there's still doubt, or these newer techniques which we talked about can come into play. So as general conclusions, I can say that distal bile duct strictures can be a diagnostic challenge, so benign causes have to be think about as well, although 70% of the strictures are malignant. Cross-sectional imaging with CT and MRI and EUS with FNA are actually the diagnostic cornerstones. ERCP is for diagnosis less prominent role, and then tissue sampling, although can be useful in some patients, and the newer techniques here mentioned can be used for indeterminate strictures. Thank you very much.
So the first case is a 74-year-old male with a history of, in 2004, a prostatectomy for a prostate adenocarcinoma. In 2009, multimodal treatment for rectal adenocarcinoma. In 2010, a left inguinal lymph node metastasis for resection and 9 months chemotherapy. In March this year, there was mild intrahepatic and mainly extrahepatic bile duct dilatation on follow-up CT scan without visible causal lesion on CT and MRCP. At that time, he had normal liver tests, and there was a management of expectation. In August 2021, he had progressive bile duct dilatation on CT and MRCP, again with normal liver tests. In September, the EUS showed a round hyperechogenic structure in the distal bile duct, maybe a stone. And then an ERCP was performed with papillotomy and passage of a Fogarty balloon with evacuation of sludge, but no clear stone. The brushing was negative. Differential diagnosis was maybe a missed stone evacuation or a prepapillar lesion. The main focus of the reason for the endoscopy today is re-evaluation with EUS and ERCP and/or cholangioscopy.
Yes, okay. Well, I think this is a challenging case. So today I'm helped by Helena de Grote and endoscopy nurses here with me, Jolien and Cindy. You heard the clinical case. I think it's a disturbing story, I would say. Patient with a history of cancer and now a progressive bile duct dilatation on his follow-up CTs without a clear cause.
First of all, we need endoscopic access, so we are going to perform ERCP. So we need a sphincterotome. Is a sphincterotomy mandatory? Not always, but we usually do one. We need a guide wire. Which one do we have to choose? We need a dilation balloon.
And on my left side, I have Professor Harald Peters, who is gastroenterologist at the St. Lucas Hospital here in Ghent, one of the neighboring hospitals. He is also associated professor at our university, and his main interests are inflammatory bowel disease, but also therapeutic endoscopy. During the session, it's important that you know that you are able to ask questions. Just post them, we will collect them for you, and we will make sure that the questions are addressed properly. For every session, we have a quiz question. Please join the quiz. You can earn GIEQs points by giving the correct answer to the quiz questions. And maybe we can display the first question for this session. I personally don't see the question appearing. Yes, so which